Welcome to the webinar on UVC disinfection technologies and what we have learned over the past 15 years. The webinar is being done with myself, Maureen Spencer. I'm an infection prevention consultant up in the Boston area. Peter Graves, who is an independent perioperative consultant in Dallas, Texas area. And Sam Trapani, who's the CEO of Sterilize LLC in Rochester, New York. So quick background on my career has been entirely in infection control since I became a registered nurse back in the early 70s. And I have a master's degree in education, board certified in infection control, and a fellow of APIC, which is the Association for Professionals in Infection Control and Epidemiology. And I'm currently an independent infection preventionist consultant. With previous positions, I was an IP consultant for Commonwealth Medicine at UMass Medical School during the COVID pandemic, Director of Clinical Implementation and Education at Accelerate Diagnostics in Tucson, Arizona, Corporate Director of Infection Prevention at Universal Health Services in King of Prussia, Pennsylvania, with over 28 hospitals that we covered in 7 states. Infection Control Director at New England Baptist Hospital in Boston. This is an orthopedic center of excellence with a lot of orthopedic surgery. Director of the Infection Control Unit at Mass General Hospital in Boston and other positions in the Boston area. Now, Peter Graves is a certified perioperative registered nurse. He has more than 35 years of experience and very passionate about perioperative infection prevention and evidence-based best practices. Peter and I actually collaborate a lot on different projects and research and ARN in presenting infection prevention for surgical site infections. And right now, as an independent perioperative consultant, he owns Clinical Solutions LLC. And his previous positions, some of it in industry, he was the head of clinical affairs at Zurex Pharma, senior director of medical affairs at Pacira Biosciences, the senior director of clinical at Aramax, clinical manager of the surgical services at Baylor, OR director and educator at other facilities in California, on the National ARN Board of Directors, and secretary and treasurer of CCI Research Foundation. And Sam is the CEO of Sterilize. He attended Cornell University and received the Bachelor of Science degree in Electrical Engineering. RD UVC Disinfection Technologies is a division of Sterilize LLC, and that's a leading supplier of ultraviolet C light disinfection technology, with the specific goal of developing area and surface disinfection methods and processes that are science-based, quantitative, and traceable. In addition, RD UVC has collected a significant amount of clinical data, and they've developed unique data analysis techniques, which we'll talk about, what's a closed loop feedback and management information for infection control practitioners. And his company is based in Rochester, New York. So during this webinar, we're going to discuss sources for pathogens in healthcare settings and describe how ultraviolet radiation works, demonstrate the administration and execution of UVC robots in healthcare settings, discuss sources for pathogens in the operating room setting, discuss how room turnovers and terminal cleaning are performed in the operating room, and discuss ideas for UVC air and environmental quality management plan. So the first thing we're going to do is a poll, and we're asking, which of the following UV devices do you use, if you know what your facility is using? So are you using an autonomous self-propelled UVC disinfection systems, almost like those robots that go around and clean your carpets and your floor? You know, they're just kind of done on their own. And then the next one is a portable one where you have an operator propelled UVC disinfection system, a high intensity episodic UVC fixed system, a low intensity, which is always on, non-UVC fixed system, or you don't know. So if you could just answer these polls, we'll just quickly see what the voting is on this. Great. That's kind of what I anticipated, that if you are using UVC devices, it's probably the operator propelled, what we might call a UVC robot in your facility. Great. Now the next question, Just have a couple of questions for you. Where are you using them? This becomes very interesting. Are you using them in your operating rooms? And select all that apply. Your procedure rooms, maybe radiology and interventional radiology areas like that, X-ray, isolation discharges, critical care areas, say like the NICU, other uses of it, or you don't know. Great. And again, I would expect that 82% they would have answered that. That primarily we started using these for the isolation discharges. And I'm going to explain why that is really, really helpful to do that. And others are using it up in the operating room and different kinds of procedure rooms. Excellent. Well, thank you. Thank you for giving us that information. So do healthcare-associated pathogens survive for long periods on environmental surfaces? And the answer is absolutely yes. There are many sources for contamination in patient rooms. You know, as an IP consultant, and actually when I was at UHS, we did full book surveys, CMS and Joint Commission surveys in our hospitals to get them ready. So seven of us, a team of 7 of us went out and devoured the hospitals. And when I would go into the ICUs especially, one of the first things I'd do is go down and put my hand along the frame of the bed. And I would then pick up all of this dust and dirt and take a picture of it. And so I used to put all the pictures in the PowerPoint presentation so I could show them what I saw through my eyes when I go to a room. And the reason I was so concerned about that is I know that the bed and the mattress and the pillow and the bed rails and all that's going to get wiped down with episodic cleaning, but they don't do that bottom area. Now, gravity pulls it all down to the floor. It gets all over that bed frame. And then I might see a fan blowing in the other side of the room, blowing at the patient. The problem is that patient's going to be confined and contained for the most part in that bed. 3 feet around the bed is the most contaminated area. And we discharge off of our body every day 10 million skin squames, of which 10% or 1 million of them have bacteria. So now what happens is this area, now typically as you're walking through the corridors on elevators, you're releasing your skin squames along the way. But here we've got this entirely highly concentrated amount of bacteria on skin squames in the bed that's going down the sides, on the floor, and on those bed frames. And as a result of that, bed rails, remotes, mattresses, IV poles, overhead lights, and so on and so forth, all get contaminated with those. Even think about the slipper socks that patients wear for slips and falls prevention. And they come back to the bed and maybe the nurse is going to help them take their socks off. These are highly contaminated. And now the nurse's hands are contaminated, but they may not think that that's a hand washing moment, that they have to go and get rid of all those organisms. A team of us, including Peter, we published a paper recently in Surgical Infections on floor contamination. And we did a whole review of all the articles that have been published looking at floors as a source of contamination. And another very interesting study by Curtis Johnsky and his team, he used a virus marker, put it on the floor, and then traced where it went. And it was on the bed rails, the bedside tables. It was out even at the nurse's station. So we now are looking at, floor contamination is a big thing in hospitals. It's by gravity pulling it all to the floor. And we can't ignore the floor anymore. The other thing in ICUs is a lot of times there may be a toilet in the ICU for the bedpans, and that thing just sends plumes out, and they don't have lids on them. We might have a water spray hose or a wand to clean bedpans that also can contaminate the area. And it's not uncommon for nurses to empty patient secretions in the room sink and brushing their teeth, the wash basins, the irrigations. And often that sink is also the sink that's going to be used for hand washing. And so now studies are coming out showing how contaminated the drains are in ICUs, especially with MDROs. Through all of these different studies, there have been numerous studies that have been published that show these pathogens can survive for very long periods of time if they're not removed first by cleaning and then killed by disinfection. So we have our challenges. And as a result of that, we have studies that have shown, they started to get published in the mid-2000s, what happens to patients who get admitted to a room where that prior room occupant had an infection with VRE, MRSA, C. diff, Acinetobacter, or Pseudomonas. So prior room occupant or cultured within the room, you can see the likelihood that that new patient is going to come down with that infection as a new HAI. So this is why it's really concerning that we've got to do better at disinfection. Cleaning's one thing, removing the bioburden, but then disinfecting what's left behind so it doesn't cause this kind of a situation. So as you know, we have a lot of challenges with EVS cleaning and disinfection. It's episodic. I mean, as soon as this worker cleans this bed area, it looks like maybe in a hallway in an emergency room, his own skin squames are going to contaminate the area as he moves around doing this kind of cleaning. And the studies have shown, and they continue to show, that less than 50% of high-touch surfaces are being cleaned. Here's one of my favorite studies in AGIC back in 2013, where they conducted a 3-point prevalence culture survey looking for MRSA, VRE, C. diff, and Candida species, and also gram negatives, including the group here. They looked at both inpatient areas and outpatient facilities. In the inpatient, they looked at high-touch surfaces from radiology, physical therapy, mobile equipment, emergency departments, the waiting rooms, clinics, and endoscopy. In the outpatient facilities, they sampled the exam rooms, also the provider areas, patient bathrooms, waiting rooms, and portable equipment. In addition to the cultures, this is what I love about this study, they used a fluorescent marker. You probably have heard about these markers that you can put on the surface, and then you come back with a UV light the next day to see, is it removed? Have they removed that? The only caution is if you use it on porous surfaces, maybe a table that has like a porous surface coating on it, it may not come off. So you want to use it on areas that, like a stainless steel is the best to actually apply it. And then you come back the next day with your fluorescent light and you're able to do an observation that this was not cleaned. It's still glowing. So when you look at the organisms, if you look at the top, the environmental surfaces, I'm just going to focus on kind of overall. So table 1, the organisms that we're worried about, these MDROs, go way over to the right. In all the total hospitals they found, out of 1,195 samples, 9% had these MDROs. Well, what's really concerning when you look below it, what was the percentage of the markers removed, the fluorescent marker? It was only 33%. Then you look down here at the areas sampled, as we talk about radiology and portable equipment and the ED, PT, endoscopy, and waiting rooms. Again, going over the top, you say that it was close to 5% that they found these MDROs in these different departments. And then the marker removal, close to 35% only. Now, when you look at the outpatient setting, this became even more interesting. These organisms, again, they sampled in these different areas. 6% of them had, the cultures came back positive with these MDROs, but their marker removal was 46% overall. And what was really great to see is that the surgery center was at 83%. So at least we know they're paying extra attention to their surgery centers. And then in their outpatient clinics, looking at the exam rooms, the provider area, the waiting room, and bathroom, you can see that they had about 4% contamination with all these MDROs in that area. And then we found that 100%, I was really impressed with that, the marker removal, 100% in the bathrooms. The portable equipment, only 48%. The exam rooms, 39%. The provider area, a little bit more, almost 57%. So these studies are, again, the ones that are behind the scenes showing us that we're not getting the level of disinfection that we need in our hospitals, or at least cleaning. They're not cleaning off this fluorescent marker. And we do have contamination with these MDROs. So this is one of the solutions, is using UVC devices as an adjunctive technology for both air and environmental disinfection. So you're going to see how these devices can kill pathogens that are floating as air current transmission, I call it. A door sweeps open and all of that stuff that was on the floor, the skin squames and lint and dander and so forth, gets moved up and it starts to move as an air current. And these UV devices can kill those bacteria as well as what's on the floor. So they really can be very helpful for us just to try to decrease the amount of contamination in our rooms. So this is the UVC wavelength. You probably have seen this before, the visible spectrum. We have UVA light, which has a wavelength of 315 to 400 nanometers, UVB wavelength 280 to 315. And then there's the UVC, which is what we're talking about and using. The wavelength is shorter at 100 to 280, and those are the wavelengths that will kill bacteria. So the shortwave ultraviolet radiation has a specific wavelength of 253.7 nanometers. It destroys bacterial, mold, viruses, and other biological contaminants, both in the air, in liquids, and on surfaces. It breaks through the outer membrane of the microbe and transmits incorrect information that results in its death. That's how it actually messes up their internal brain system. The UV irradiance, also called fluence rate, is often expressed as microwatts per square centimeter. So you'll see this very often behind, how much radiation is being delivered by that device. And the dose of UV received at a surface during a specific time of fluence is calculated by multiplying the irradiance times the number of seconds of exposure at a surface. So the pros of UVC, it's a known disinfectant for air, water, and non-porous surfaces. And you'll see as Peter talks later about a UVC quality management program, that can include even the UVC that's used for water systems in water management programs. High effective at eliminating both vegetative pathogens, including the MRSA, the VREs, the CREs, the multiple drug-resistant Acinetobacter, and spores, such as the C. diff and most viruses. They actually, thank God, are easier to kill than, say, something like C. diff, or the highest one is anthrax, as you'll see. Now, some of the cons is can only inactivate bacteria and viruses if directly exposed to the radiation. So that's why things that we call shadows can be an issue, or why you might have to do several treatments in a room in order to get all the surfaces disinfected to get that radiation exposure. Inactivation may not be effective due to blocking of the UV radiation by the shadows, the soil, and dust, or other contaminants such as body fluids. So all of that dust that I talked about on the bed frames, that's not going to kill bacteria if they're still in there. If we have that amount of bioburden in that has to be cleaned first, and then the surfaces are disinfected. The efficacy degrades with distance from the source. Therefore, you need to reposition the device. Problems with exposure from healthcare workers. So the rooms have to be vacated. You make sure that there's no skin and eye exposure to the radiation that can cause eye injuries and burn-like skin reactions. And most of these devices do have a mechanism by which the room is locked, that it won't go on unless that room is vacated. Requires staff to maintain it, to move it and store it. There can be substantial capital equipment cost and maintenance contracts when you first get into this and start to get these devices. And that open loop systems are most of the devices versus closed. I'll talk about that a little bit more. And that results in a lack of quality control for correct doses for the pathogens in the systems on the market. So here's a study by Dr. Elizabeth Bryce and her team at Vancouver General Hospital, where they looked at post-discharge decontamination of MRSA, VRE, and C. difficile isolation rooms. And they compared two different devices that look somewhat similar, but one is TruD UVC disinfector. This lights automatically delivers the lethal UV doses using a 360-degree sensor. It has two settings, one for bacterial and one for sporicidal. And the machines uses a reflected and direct UVC. And they compared it to the RD UVC disinfector. Similar technology, but it allows repositioning of the machine with only one setting for all the organisms. And their results show what we're talking about, that look at before manual cleaning for MRSA, VRE, and C. difficile. After manual cleaning, there was a statistically significant reduction in MRSA from 13.9% down to 5.8%. But the point is, there's still 5.8 remaining. VRE 6.9, C. diff 4. Now we look at adding in the UVC disinfection, and you can see the reduction. So it's an adjunct. So first you do the cleaning, and then you do the UVC disinfection. The differences they found between the two systems was really related to the time to do the disinfection procedure. So the TruD system took for MRSA and VRE 35 minutes, for C. diff almost up to an hour. For the RD disinfector, it took only about 15 minutes, less than 15 minutes to do the treatment. We'll talk about why that system has a lower time for disinfection activity. So the results in evaluating these two systems, the both machines are microbiologically effective. They do work, both of them work. The functionality and integration into workflow became the primary determinants. And the RD was the preferred machine because the ability to reposition the sensors. So they have sensors that you put on the floor that are able to decrease operating time. They have a Wi-Fi tracking of the rooms with a software system to record and monitor results. So the built-in quality control system, single cycle option, ergonomic considerations, and a faster kill time, which for surgical throughput, emergency department throughput, nursing unit throughput, this is really important that we can get equipment in that has a shorter kill time so we can move that on to the next room and get work done and not have to take maybe up to 35 minutes to an hour to get it done. I just wanted to speak a little bit about my experience with RD disinfection, why, when I was contacted about this webinar, I was excited to participate in it because I actually did choose this one as the UVC robot for the universal health system for their disinfection robots. But my first exposure was back in 2008 when I was at New England Baptist Hospital in Boston, the orthopedic hospital, and they approached me with a device, which actually ended up being the TrueD. It was in early days of it coming out, and asked if I could do a study. We would do a lot of environmental studies. I worked very closely with my microbiology lab. And we had a vacant nursing unit. And so the laboratory director applied a 0.5 McFarland broth of Staph aureus and E. coli. And then we showed significant log reductions after treatment, more than 3 log reductions. And this nursing unit had not been cleaned. It was full of kind of dust because it had been sitting there for a period of time. So it was just testing it and seeing what these things do and how the door had to be closed and nobody could be in the room and all of that. In 2011, I co-presented actually with Anne-Marie Pettis from the University of Rochester on environmental decontamination with innovative EVS technology. During that period of time, we had an outbreak of C. difficile in our emergency department at the New England Baptist Hospital. We traced it to a bathroom that was being used by not only healthy patients, but the patients who were on isolation. They didn't have a separate isolation bathroom for them. And so this room was heavily contaminated, caused the C. diff. I was able to trace it all back by saying, where did these patients come in when they were admitted to the hospital? And I found it was the ED. And we had a company called BioQuell come in with vaporized hydrogen peroxide and saturated that ER, pulled out all the drawers and opened up all the doors and completely, got rid of the C. diff, and they had no more cases from that point on. We then put into place commode liners and commodes that they would have to use commodes in the isolation rooms. 2017, I was at the APIC Rochester chapter conference presenting, and during the exhibits, I met the Sterilized company, and I was very impressed that the fact that they have, you can see them in the picture, these 4 sensors that you put around the room. So it's going to assure with quality control that you got the right dose, the adequate dose for killing C. diff spores, which one is the most difficult. So if you can get C. diff, you've already wiped out MRSA and VRE and viruses and so forth. So the key thing is that their dosing goes up to the C. diff level. And then in 2014, we initiated UHS corporate contract with Sterilized Disinfectant, and that's history. Everything took off from that point. But some of the reasons, you want to also look at this quality control program, you want to see, is it reaching the shadowed areas? These proper UVC doses get all these points of interest in your desired area, including the shadowed areas. Are you measuring the required dose? So these patented wireless remote sensors were confirming to me and at corporate that this device was absolutely eradicating the pathogens. It was a fast throughput because of how quickly they can get these treatments done because of those sensors. It records comprehensive data. This was great at a corporate level. I could look at all those 28 hospitals, all of that data coming in, and then our epidemiologist who worked with me, she would take that data and start comparing it to our C. diff rates and MRSAs and looking at those rooms, room tracing, so that we were able to show our corporate C-suite that this was worth the money, that this equipment works. And then the utilization data lets you know which areas have been treated by whom, how often, and the time spent per area. So this just gives you an idea of the pathogen. The amount of those microwarts that have to be to achieve killing E. coli is 7,000, SARS-CoV-2 10,000, MRSA 11,000, influenza 26,000, C. diff spores 46,000. So that's what their machine is set at. But if we thought we had anthrax, or another one that should be in here is C. auris. C. auris is 60,000. So if you're having an outbreak with C. auris, you've got to get these kinds of devices in, but make sure they're going to give you the 60,000 microwatts for treatment. But anthrax would be the highest one. That's a high energy of 106,000 microwatts. So as I mentioned earlier about open versus closed loop, just describe that for you. So an open loop system is what most of the devices are using. It's timer based. It operates for a set time based upon the targeted pathogen type and room dimensions. It also uses this laser technology to measure distances to objects or surfaces by mapping the room to calculate the treatment time. And typically the LIDAR-based system requires 3 TOWIE units to be deployed. So sometimes you may have a company come in and say, well, geez, our system is 50% less expensive than that system there. But they don't tell you that you're going to probably need 3 of these units to be deployed to do one room. And neither type uses sensor technology to measure in real time the dosage levels. So the uniqueness, when I saw it, I just was like, wow, this is something I want. I want a closed loop machine that has this one measurement capability, emitter mounted sensors or remote sensors that enables the measurement of the delivery dose. And the emitter mounted sensors are of limited efficacy as they rely on reflection. So this one has remote sensors. Many of the others have emitter mounted sensors, which are bouncing off of walls, maybe kind of get to the floor, but usually it's the walls or some of the other surfaces to gauge the dosage that gets delivered. With the remote sensors, you're getting the 46,000 microwatts for treatment of that area. And then the machine will tell you, move, go to the next area now, move, go to the next area. So they can get each side of the room and then the bathroom done in less than 15 minutes is what we found in what they found in that study, Dr. Bryce's study. So some of the issues that we have is we need more of these systems. Usually you start to get 1 or 2 of them and start using them for isolation rooms. And then they start seeing infection prevention might be working with EVS and the infection control committee saying, we really could use these in the nursing units, maybe have 1 per nursing unit. We really need them in the ICU and other departments. So that becomes a problem where it could start to get in the capital budget problem of being cost prohibitive. You also have you have FTE requirements for using this equipment. Somebody has to move these around. There's education that has to be done, reinforcement of IFUs. UV autonomous disinfection robots seem like the answer. But the problem is that it's very costly, this equipment, but you still need FTEs to operate. The other problem is you have limited UV output due to battery life. So they're not going to go and run for a long period of time. You have to then recharge these systems. The disinfection treatment greatly reduced and limited to the system battery life, and charging time is more than double the actual utilization time. So here's a paper that we published in AGIC in 2016, looking at the evidence that demonstrates persistence of contamination of environmental surfaces despite traditional cleaning. We talked about that. Need for this adjunctive secondary disinfection technology. Talked about that. UVC disinfection, that's one type of no-touch technology that's successful. The dilemmas for the IP is how to choose the system best suited for their facility among the many different types, and build a case for acquisition to present to the hospital administration. When we did this at UHS, we had a team that included quality and nursing and pharmacy and environmental services. We had the plant operation team, emergency preparedness, and myself. And we all sat and had vendors come in and do a vendor show for us, one after another. So we were able to see our choice was the RD disinfectant because of some of the reasons I already mentioned. So you want to engage an executive champion and educate and serve as the insider sponsor to the entire executive team, which is what my role was. Create a multidisciplinary team. I just described what ours was. Propose how the UVC disinfection would deliver a measurable return to the organization, and share the current rates for high-risk pathogens, which is what we did to be able to show administration that it was worth the money. We were reducing, as we looked at the different isolation rooms that were getting done, we reduced that cross-contamination to the next patient. So there's some key steps in this selection process. You have education on the options and their attributes. You analyze your facility needs, and you build a comprehensive business case for how to, cost avoidance, return on investment, reducing hospitalization costs, ED divert times, operating room case cancellations, reduce CMS penalties, among others. So there are different kinds of things you can look at, process and clinical outcomes as part of that business plan. So we developed a strong implementation plan. We had in this paper an example of system specification comparison checklist. So we had the first thing was the capital cost service and support agreements. So system A was annually, system B was annually, and system C, that was included in their price. The UVC lamp cost, the UVC dose measurement, the data capturing capabilities, the UVC dose-based repositioning capabilities, the estimated treatment times, and then the physical footprint of the system. So once you've selected your technology, engage the manufacturers to help you create an implementation plan to optimize utilization at your facility, and request training sessions from them, not just for the operators, but we provided education to the directors of EVS and nursing, the ID docs, corporate. So everyone involved understood how these systems were going to work as a disinfection system in our hospitals. So the infection tracking software, which has patent pending right now, this gives you an idea of what the dashboard looked like at UHS that I would pull up. And I would look at, this happened to be one of our hospitals, Aiken Regional Medical Center, room disinfection job summary. And it would tell us, the data range, it would tell us the locations, the job status. So I could go in and check these things off if I was looking for a particular day where maybe I was correlating that with an increase in infections, on a particular week, and going back to see, did the jobs get done? So you get the device, the job ID, the create time, the operator, the location, the dose, the sensor readings, the elapsed time, and the final status. So this just gives you a little slice of what something like that would look like. This happened to be the operating room. So look at OR, look in the middle, the location, operating room 8. You see 1, 2, 3, 4 treatments. Look over to the elapsed time, 4 minutes, 3 minutes, 3 minutes, 4 minutes. Less than 15 minutes, the entire OR 8 was completed. So those are the things we would look at. Are they doing the treatments correctly? We getting quality control built in, and of course, at a corporate level where I can justify the cost of this equipment. So the conclusion was the continuous UVC room decontamination works effectively in reducing contaminants left in the environment after your routine cleaning and disinfection with sandy cloths or microfiber mops and so forth. You then bring this in to get whatever was left behind. The RD disinfector room decontaminator has a built-in quality control program with these 4 remote sensors that assure the correct dosage of UV that's being achieved during the treatments. It's faster and more efficient, and the software really helps IP and EVS and other departments to monitor compliance with the use of the treatment and to treat the rooms and the surfaces. So I'm going to turn this now over to Peter, who is the independent perioperative consultant that I work very closely with. And he's going to be talking about the operating room and the disinfection procedures and the use of UV disinfection devices. So I'm going to stop sharing and I'm going to let Peter come on.
All right. Thank you, Maureen. Great job. So welcome, everybody, and thank you for joining us. We're going to talk a little bit about the operating room and the use of UVC disinfection. And I think there's a perception that everybody has about how clean the operating room really is. And I think it's kind of important as we are thinking about this on some of the studies that have been done as it relates to environmental cleaning within the operating room. And 2 studies, I kind of look at these as pivotal studies. The first one by Munoz Price only showed about half of the ORs in a large urban teaching hospital actually had their rooms properly cleaned. My colleague, Julie Jefferson, who I served on the recommended practices committee with, did a study that was even more, for a better term, a little bit earth-shattering, showing that about 25% of the objects in the operating room in 6 acute care hospitals actually cleaned their surfaces appropriately. What they used was, both of them, as Maureen mentioned, they used a fluorescent marker to be able to identify surfaces that needed to be cleaned, and then they went back and assessed them. And what they found, obviously, was more than half were not clean. So that's really a call to action for all of us in the operating rooms to really focus on the importance of environmental hygiene. So in a study that looked at using these cloaking, fluorescent cloaking devices, many people will use things like blowgerms, for example. But Dr. Munoz-Price, in her study, looked at, much like what Maureen showed, was the baseline cultures of different pieces of equipment within the operating room. Now we'll talk about anesthesia in just a moment, but if you're looking at the beds, for example, 11% of them were not properly cleaned. That's tremendous. Almost 1 in 5 IV poles and pumps weren't cleaned. The same thing for the circulating nurse back in the prep area, prep stand area. Almost 1 in 6 were not clean. But when they did education, letting the staff know that they were using these fluorescent markers to actually assess and track quality of cleaning procedures within the operating rooms, you saw a significant improvement. Not perfect by any means, but a dramatic increase in cleaning. So when we think about the importance of UVC in these systems, in your hospital, in your clinic, think for a moment that we might not be having adequate cleaning taking place and putting our patients, ourselves, at risk. Our colleagues in anesthesia have a unique situation in here. Again, another study by Dr. Munoz-Price looking at anesthesia. This was done as a SHE expert guidance document. She was the primary author. And what they did was they looked at all the different aspects in and around anesthesia. Anesthesia machines, challenges with their anesthesia supply carts, their supply rooms, keyboards, a number of different issues. They came up with some guidance documents that would be very helpful. And one of the questions they asked was, should anesthesia machines be partially or completely covered with disposable covers to prevent contamination? Well, that's not always practical or possible. One of the challenges that we have is that as we do turnovers in our rooms in between patient care, there's a lot of very intricate knobs and buttons that are on these anesthesia machines that are very hard. A term I used to use in the operating rooms, there's a lot of nooks and crannies that we have to be able to clean inside and around on an anesthesia machine, which makes it very difficult. This is one of the reasons why UVC is an attractive option for this reason alone. When ORs are prepared between uses, what cleaning and disinfection of anesthesia machine and anesthesia work areas should take place? Well, one of the biggest challenges that we see for our anesthesia colleagues is the issue of hand hygiene. It's been well acknowledged in the literature that hand hygiene is less than ideal for anesthesia. And that turns into, much like what Maureen described earlier about the transmission from the environment to different surfaces. The same thing can happen within the anesthesia care area. So again, I think it's important for us to recognize this. How should keyboards and touchscreens in the anesthesia work area be cleaned and protected? Do we need to use covers for them? How do we wipe them down? What do we use? What infection prevention and control modifications should be made, if any, particularly for patients in contact isolation? Do we need to run a cycle, a UVC cycle, before the next patient comes in? And then environmental cleaning. What practices for cleaning, handling, and processing of anesthesia equipment have been published by AON? And it's quite extensive. AON has the Environment of Care guideline, which actually starts off with that 2 studies of the Munoz-Price study, as well as the Julie Jefferson study, looking at the lack of cleaning. But when we look at the environmental cleaning, we look at room turnover in between those cases. And it's defined as the time from when the patient leaves the room, their wheels out of the operating room, to the time when the wheels of the patient's bed enters the operating room. So wheels out, wheels in. Excuse me. Now, typically benchmarks for turnover within operating rooms are anywhere from 20 to 45 minutes. And there's really no standard benchmark per se. But typically you'll see that 20 to 45 minutes, depending on the complexity of the case. But I was actually touring a surgery facility, an outpatient surgery facility. And they said that their turnover time between arthroscopy cases was 4 minutes. And I was a little perplexed because I've done a lot of arthroscopy cases in the operating room. And it takes far longer than 4 minutes just to clean up the moisture on the floor. So I asked them, I said, so what are you using to clean the surfaces? And they told us they were using wipes. I said, can you go get me a canister of the wipes and tell me what is the dry time for those wipes? And they described it as 10 minutes. And I said, that's your minimum turnover time. Because you have to allow the surfaces to completely dry before you bring the patient in. See, in the operating room, we're going to have bodily fluids, blood, body fluids, and so on surfaces. And in order to be able to use UVC, those surfaces actually have to be physically clean. Like Maureen mentioned, you can't have dust and debris on surfaces and expect that to be cleaned underneath by UVC. So we need to make sure that we're doing this properly. And many facilities actually have, they call them pick crews or turnover teams, whatever the acronym that you're using, but they're very focused on cleaning the room thoroughly. But we still need to make sure we're tracking those patients, or tracking those procedures and how we're cleaning. So we need to make sure we're cleaning and disinfecting items that are used during a surgical or other invasive procedure. This includes the OR beds and all the attachments. That includes arm boards, stirrups, headrests, and other posts and fracture tables, those type of things. Other positioning devices, and we have lots of them because we put our patients in some interesting positions. I just had my hip replaced about 5 weeks ago. They put me on a pegboard with a beanbag. What about transfer devices? Oftentimes facilities will use roller boards. Some will use hover mats. Others will use pull sheets. Making sure we clean the overhead procedure lights, both the lenses and the top. Making sure that they're dust free. Making sure all the OR tables and the mail stands are clean. What about mobile and fixed equipment? What about those specialized pieces of equipment like C-arms, for example, that need to come into the room? Are they being cleaned? What about their wheels? So we need to make sure, and Maureen was absolutely correct about the importance of disinfecting the floors, but also the walls of the operating room and procedure rooms are just as important. Typically, what AORN's recommendation is to start from the clean and work toward the dirty. So kind of the outside in. But we need to make sure that we are removing all soiled and potentially soiled materials off the surfaces before we run a cycle. At the end of the day, or over the night shift, we typically clean our rooms, we terminate from our rooms. So we need to make sure this takes about 45 minutes to an hour to physically clean the room, wipe all surfaces, disinfect the floors and all the periphery. We need to make sure that we're using either a wet vac or a single-use mop with a EPA registered disinfectant being used according to the manufacturer's instructions for use and the facility's procedures. We need to clean, as I mentioned earlier, from cleanest to dirtiest. And then we need to disinfect the floor. It was pretty interesting when we did that study that Maureen talked about, looking at the role that shoes play in dissemination of bacteria and viruses throughout the floor. You know, we were able to show COVID was tracked all over facilities, including in the medication places where you wouldn't see these patients. And the same thing's true with operating room floors as well. And then again, we need to make sure that we're disinfecting all exposed surfaces. That includes wheels, casters, and all items within the room. There's an interesting system that's available. It's a adjunctive RDFX mounted system. It's mounted around the room, usually at the highest point, strategically located. And it's designed to be able to flood the room with enough UVC energy that that dose is able to provide a 3 log reduction of the targeted pathogen. Now, the nice thing is that this system, which is activated from outside the room, can be programmed on a variety of different pathogens. So as Maureen said, if we are trying to go after, for example, C. diff or Candida auris, for example, then you're going to want to make sure that you're going to have enough energy being delivered to be able to achieve that specific kill rate. So after each procedure is complete, you can do a manual clean. So the individuals in the room would vacate the room, exit the room, close the door, enter a user-specific PIN number. This would log them into the system. They would select the desired dose. Again, this could be pre-programmed for multiple different doses for specific pathogens, for example. They hit the start button and it begins the disinfection cycle. It shows a countdown clock and indicates when the process is completed. The nice thing is, which is important for all of us, the disinfection data, which includes the room, date, time. Maureen shows you one of those reports. Is posted to your cloud portal immediately after it occurs. So it's in real time. And when completed, the room is immediately available for the next patient. Depending on the setting you take, this cycle can take as little as less than a minute or up to 3 minutes, depending on the organism that you're trying to eradicate. Well, what about quality management programs? UVC is used in a wide variety of products or processes. So if you think about it, you could be possibly using UVC right now within your system for water disinfection. They're using it in water plants, for drinking water, reclamation, life sciences, aquariums, pools, spas, water treatment systems, and a number of other uses within the water disinfection processes. What about surfaces? Hospitals, nursing homes, daycare centers, restaurants, food buffets, grocery stores, food preparation areas, medical supply, manufacturing, and a plethora of others. Air purification. ARN's Environment of Care talks about air quality and air management processes taking place within the operating room. One of those systems actually employs a UVC light inside their filtration unit. And what it does is it eradicates the airborne bacteria and viruses and fungi that is found within the operating room. Remember that every time we open the door of the OR, it changes the air pressure, and that also allows air into the room and out of the operating room. And it takes a little bit of it takes a period of time for that room to recover, and that becomes an aerosolization. In addition to that, we look at lint and other things on the floor that, as we move around, can become problematic. So air purification becomes a very important topic within the operating room. And then medical equipment disinfection. Again, if you think about all of the intricate aspects of an anesthesia, UVC does make perfect sense to be able to clean their parts and to help clean their anesthesia machines as well. So some of the purposes of a UVC quality management program. So Maureen did a nice job talking about the importance of how to select a UVC device. But again, you need to use an interdisciplinary team. You need to review and evaluate the levels of evidence, particularly from the manufacturer. Look at the laboratory data. Look at the clinical outcomes. What about the hazards? Every UVC device has potential hazards. You will recognize those. What about installation issues, logistics? What about vendor support, service plans? These become very important so that we don't have downtime. What about the cost of consumables? That becomes a big issue about cost of use. Replacement of bulbs, maintenance, upgrade. What about the equipment selected? Where are you going to use it? By whom? Where are they going to be stored? Almost every operating room I've ever visited, and I've been to a lot, has issues with storage. So that needs to be addressed. In-service education, prevention, preventive maintenance plans, analysis of treatments, and looking at your hospital-acquired infections and multi-drug resistant organisms. You need to look at the reports. You need to track the outcomes after you've launched or deployed these systems within your facility. So there is a number of different UVC quality management. This is adapted from the CDC. But you have to be able to look at the quality, the management of the program, and then again, what is the program going to look like? And then the team that you're going to use. You need to be able to have oversight of the entire program. You need to have knowledge of the UVC system. You need to have the ability to identify, control the locations, and control the limits set on what these systems are able to deliver. You need to have the ability to identify and take corrective action when something is amiss. You need to have the ability to monitor and document program performance. This is why being able to see reports are so important for all members of the team. And the ability to confirm the program performance and communicate findings. I think it's important to communicate to everyone in the operating room so that they understand why we're doing what we're doing and they can see the benefits and the results from deploying these UVC devices. As I mentioned earlier, the importance of an interdisciplinary team, we use it for all sorts of different things. Whether it's going to be selection of a disinfectant, for example, but we're gonna look at making sure we include anesthesia, perioperative nurses, sterile processing, environmental services, infection prevention. You know, it's interesting. Maureen and I kind of laugh about this a little bit, but we're probably modeling the ideal behavior between the perioperative leader and an infection prevention leader. And AORN is seizing on this because it's important that we work together as a team. So we work together by selecting what cleaning products we're going to use, what disinfectants with shorter contact times we may want to use within our operating. We want to make sure that the equipment that we choose to use, whether it's mops or cloths or wipes, are going to perform adequately. So we're going to want to use those masking agents to be able to check, to monitor for those, and assess for efficacy. We want to use turnover kits and packs so that we can accelerate the turnover time. We want to use adjunctive technology such as UVC devices to help reinforce cleaning. Because if we go back to those first two studies I talked about, we're going to miss things. We need to make sure that we're catching them with technology. We want to make sure we have our policies and procedures in place in order to make sure that everybody understands how this process is intended. In-service education for everyone so that we know how to safely work with it and work around UVC. And then staff competencies, and then quality monitoring systems. All of these, just like anything else, is important. So we've talked a lot about UVC over the last about 50 minutes. But I want to make sure that we discuss the source. What we talked about was discuss the sources for pathogens in the healthcare setting and in both inpatient and outpatient. We reviewed how ultraviolet radiation works. We've demonstrated how to administer and execute it in various healthcare settings. We've discussed sources for pathogens in the operating room. We've reviewed OR turnover and terminal disinfection procedures in the operating room. We've illustrated how fixed ceiling UVC systems can be used in the operating room quickly and easily deployable. And we discussed the UVC plan and interdisciplinary team for implementation. We have a couple of surveys that we want to show. So are you utilizing your UVC equipment as much as possible? Answer yes, no, I don't know. We have an opportunity for a little bit of an improvement. Does your organization review the UVC treatment report? Answer yes, no, I don't know. I see that the majority are reviewing the report. And the final polling question, do the treatment reports provide meaningful metrics that trigger action when limits are reached? So here are some of the references that Maureen and I used during our session. I'd like to take just a second and introduce Sam Kapani. He's the CEO of Sterilize. He's going to talk about the updated technology in the future and FDA 510K issues. Sam?
Thank you, Peter. Good afternoon. I'd like to thank Maureen and Peter for their thorough review of UVC disinfection technologies, past, present, and future. It's clear from the studies presented that UVC is highly effective in eradicating harmful HAI pathogens. And the studies show our system's closed loop system has the highest efficacy and shortest treatment time, with shadowed areas being reduced because of our patented pause and reposition process using remote sensors to ensure the required dose is delivered every time. Historically, the most difficult concept to get across when we're doing presentations is the fact that a dose is not the same as time. What is the dose delivered by an open loop or time-based system? It's anyone's guess. There are no guarantees. That's why you need a closed loop system like the RD system. And as far as autonomous robots, those that move by themselves, they are too expensive to purchase and maintain, so hospitals can't purchase as many machines as they really need to get the results needed. Hospitals need more systems, not fewer systems. The ultimate scenario is for each unit to have their own system so that the resident EVS person can use it on every discharge, terminal clean, every time. This eliminates time-intensive and labor-intensive transporting of the machines from location to location, thereby increasing utilization. Using the every room, every discharge model, the machine is always available for use on the unit at any time by the already present FTE. As the number of rooms treated with UVC upon discharge increases, the total pool of pathogens in the hospital will decrease. That's the target, every room, every time. So at Sterilize, the way we view the future of UVC disinfection in healthcare facilities is to provide more effective systems that are widely available throughout the hospital with lower costs of ownership and improved ease of use. That's the winning model. One last note about the recently added FDA 510 category for whole room microbial reduction devices. Sterilize is presently preparing our 510K submission for our products. In several discussions with the FDA, it was made clear to us that there is no FDA mandate to hospitals requiring them to only purchase 510K cleared UV devices. Any hospital or healthcare facility that fall under regulation by the FDA may purchase and use any UV device they choose for whole room microbial reduction. It does not need to be 510K cleared. If you'd like any additional information from me on the FDA issues or any anything else from today's webinar, please feel free to reach out. And thank you all for attending. And now we'll address the questions. I'm not sure if this webinar continues, but we're ready to do that.
Right. Thank you, Sam, and thank you, Peter, for a great presentation. One of the questions was, how does the system determine the precise amount of UVC light? I'm going to give that to Sam. How would you answer that?
Our portable systems have the 4 remote sensors that you spoke about, Maureen, and they are electronic precision devices that are calibrated periodically, and they measure the actual amount of UVC light that's incident upon the sensor face of the device. That gets reported back in real time to the emitter, where the computer there then computes the cumulative. I hope that answers your question.
Yeah, I mean, that was what I thought. It was just the sensors as they're around the room will pick up on that 46,000 microwatts of UVC. Are you able to quantify a return on investment on the usage? I think that what we did at UHS, I left at the end of 2016 at UHS, and we had, I was the corporate director, and I had a corporate director of epidemiology with a master's in public health, a nurse, Jackie Christie. And I know that there was a lot of work at looking at the C. diff rooms, especially kind of focused, because that in our metrics of HAIs was our highest HAI. So we kind of had a team approach to look at reducing our C. diff rates and contamination in the rooms. So that was one of the things they did. I remember them looking at the different isolation rooms where these cases would go and how many treatments were done. And then follow up, did anybody after that got admitted to that room, like those studies I show, get infected? But it was more from that point of view as we started to use the technology, seeing our rates of transmission go down, cross-contamination. You know, sometimes people come in with C. diff or they develop it from the antibiotics, which is the #1 cause of C. diff. And you would have surgical stewardship, antimicrobial stewardship team involved as well. But we would then look at our MRSA and C. diff rates coming down. And so that was how we looked at return on investment. I don't know if there's anybody else on the webinar that had some other kind of measurement that they used to look at it, but I know that was one of the ways we were able to show our C-suite the return on investment, and that resulted in them buying many more systems. I think when I was there, maybe they had 24, and I don't know, they might have over 50 now systems in place. So anyway, and then the question: have you seen any issues with equipment damage over time with using UVC disinfection in the OR? I do remember some discoloring of, I don't know if they were the booms or there was some kind of a discoloration, like it turning a funny yellowish color. I don't know, Sam, if you can address that. I think that comes up a lot. I don't know any equipment got damaged, but it might have just the outside surface got a little bit changed in color.
Yeah, so the handle on some of them are disposable. The handle on the boom of the light is a clear plastic sometime. Yep. It's important to note, a lot of manufacturers have now changed their formulation of the plastics they use to include UV inhibitors.
Okay, great.
So that they don't get damaged, because they know that UV is widely used now. And but those discolorations, interestingly enough, would go away after a period of several hours and return back to its normal color. UVC is a superficial technology. It's non-ionizing, so it does not penetrate people or surfaces. And if any damage does occur, it's on the outside only, and it's not really going to impact the performance of the device.
Okay. And this is a great question. Is there actually a smell in the room after each treatment? I do know that we did have that in that 2008 study. We noticed that smell, and I remember them saying, well, it depends on the bioburden. It's like bleach, bleach wipes. Gosh, when we started using those, everybody's complaining about this bleach smell. But as the nursing unit got cleaner and cleaner, there was less of the bleach smell. So that's my understanding. There is kind of an odor. I remember the safety officer getting involved, making sure that it wasn't going to harm healthcare workers, like smoke in the operating room. So Sam, anything on that about the smell?
Yeah, so the smell is photosis, which is the oxidation of the burning, really, of the fatty particles in the air and on surfaces.
Yep.
And as the burden decreases over time, the more treatments you have, the less
Yep.
remaining burden is there. So, for example, in a brand new hospital, you don't get much smell. In an old hospital with lots of bioburden, you do get the smell.
Right.
Does
Right.
decrease over time.
Yeah. Good question. We would tell the nursing team that you can tell the machine is working when you smell that. Robert, yes, I said that. I remember with the bleach thing, like, that's great. That means that it's interacting with the organisms, the same with the UV. So that's a good way to deal with that question if it comes up with your staff. Thank you, Robert.
It's good.
Um,
And the smell, by the way, is non-toxic. It's won't you can go on immediately afterwards, not like
Yeah.
hydrogen peroxide or anything else.
right. So it's a good smell. And what about heat? Somebody questioned. Is that heat from the system, but they wouldn't be in the room with it, but is there any heat left over in the room? The room is warm after a treatment?
Well, so, basically there's no free lunch. Energy is energy, and most of the systems that are portable plug into the wall and they take as much power as possible out of the wall. So they're going to all use about the same amount of energy, 15 to 17, 1800 watts. And that's going to get converted substantially to heat. So if you have a system that's faster, less heat will be generated. The longer the system has to run, the more heat. So that's another consideration. You want a system that's fast.
Yep. Yeah, I could imagine with one that takes up to an hour, that room would probably get warm. Yeah.
And
So
not
thank
only
you.
is the long running system, like in the study that you had pointed
Yeah.
out, it's also going to have 5 times roughly the impact on the degradation of the surfaces of the room because it's running for a much longer period of time.
I see. I always say it's the new smell or of clean, just like people got used to the bleach and the chlorine. Exactly. Thank you, John. Okay, thank you.
These are
I
great
think we're
questions,
gonna
by the way.
probably wrap up now, right? Peter, you have anything to add about the operating room?
I just think that this is a great opportunity, particularly for places that are concerned with HAIs within the operating room.
Yeah.
Total joint programs, heart programs, transplant programs, anything with any of these type of high risk procedures, that this is a system that totally makes sense. It turns to be cost effective over time. Reduce a couple of HAIs and it starts paying for itself pretty quickly. So I think that's really important. The other thing is that this is the question that we typically get. Can we get a copy of your slides? Everyone will receive a copy that registered for this program of our slides so that you'll have them. We'd love for you to take them back and use them with your institutions. And the only good information is ones that are shared with others. So.
Okay. I think we're going to end it here. I want to thank you all for staying on an extra 10 minutes. And if you have any other questions, you can reach out to us.